What about pressure on nerves? Well, if there is pressure on a peripheral nerve, then the main symptom the patient is describing is a kind of numbness feeling, more than paresthesia and more than pain. And the patient is describing a clearly defined area. He can tell you, well, it's the medial side of my finger, but not the lateral side. Yeah, it's really to the point. If the patient has pressure on a nerve trunk, then paresthesia are the main symptoms, more than numbness and pain. And this time he's not able to clearly define the area. It's more vaguely described. It's, somewhere over there in this finger, but it's more vague. And typical pressure on a nerve trunk is a release phenomenon. And we all know that. You sit for sometimes crossed with your legs, you have pressure on certain nervous structures, and then you stand up again, and then suddenly you have a shower of paresthesia in your feet. This is an example of a release phenomenon. But later on, we're going to see an even more important example. If there is pressure on a nerve root, then the first symptom is going to be pain. More pressure on the nerve root, paresthesia. More pressure on the nerve root, numbness. And finally, ending up in weakness. The patient is going to describe segmental symptoms. And this is a clearly compression phenomenon. And pressure on the spinal cord, well, one of the key elements is that the patient is going to describe multisegmental bilateral paresthesia. And for instance, neck flexion can cause paresthesia in both hands or in both feet. A carpal tunnel syndrome is a pretty frequent lesion where we talk about the compression of the median nerve. And of course we have to make a differential diagnosis with a cervical disc protrusion compressing a nerve root and a thoracic outlet phenomenon, but we're going to do that a little bit later on. In fact, we can't miss a carpal tunnel syndrome. Actually, different factors can play a role, mechanical factors, vascular factors, which influence the structures in the tunnel. There could be a link with tenosynovitis, with diabetes, with pregnancy, obesitas, rheumatoid arthritis. External factors such as trauma, repetitive strain injury, gripping activities, squeezing activities, vibration activities, unergonomical keyboard use, and so on. I remember that one of my patients was an orthopedic surgeon who had a problem, such a problem, and it was related to the pneumatic drill he had to use during surgery, and that really made his symptoms worse. What are they telling our patients? Well, they have a kind of aching, burning sensation. They have some paresthesia in 3.5 fingers, or part of this 3.5 fingers. About 70% of the patients, they describe numbness at night, and about 40% describe radiating pain proximally into the lower forearm, together with paresthesia in the fingers. And this is a little bit strange, I must say, that the pain is radiating in a proximal direction. Patients may wake up at night and they have to stand up, or they shake a little bit with the hands, or they rub the hands to get a more comfortable feeling again. They can also complain of a loss of dexterity and sensitivity. They become clumsy, and specifically those increased symptoms at night seems to have a pretty high sensitivity. In the functional examination, there are several tests we can use. For instance, flexion extension of the fingers, while the wrist is in extension, and at the same time you exert compression of the median nerve, then that's going to provoke symptoms. Or sudden wrist extension after being 1 minute in flexion can also provoke the paresthesia. Of course, you are familiar with the Tinel sign, which seems to have a pretty good sensitivity and specificity. Or Phalen's test. Yeah, you keep the wrist in maximal flexion. And a carpal tunnel patient will report pain, numbness, and paresthesia within about 1 or 2 minutes. And if the symptoms are not reproduced within 3 minutes, then the test is considered negative. Again, high sensitivity, but a very low specificity. What about upper limb nervous tension tests, which are also very, very popular? Well, here we have the same problem as we so often have. There is a discrepancy between one side the sensitivity and the other side the specificity. Yeah, we don't seem to have good tests to rule out a diagnosis of carpal tunnel syndrome by using those upper limb nervous tension tests. So this is one of the reasons why we didn't do those tests in our basic examination of the wrist and the hand. A carpal tunnel syndrome can react well on infiltration, but the emphasis is on the word can. Sometimes we have good results and sometimes we don't. It's quite possible there are also structural problems over there, and in that case, of course, the surgeon has to create space. And certainly when there is already weakness of the thenar muscles, then surgery is advised. Is there a link between a carpal tunnel syndrome and cervical range of motion? I came across this interesting article. Women with carpal tunnel syndrome show restricted cervical range of motion. The question is there a causal link? And this is a little bit the problem. Is the restricted range of motion a consequence or a promoting factor in women with carpal tunnel syndrome? So that's not 100% clear yet. And it's also quite possible that the restricted range of motion may be the consequence of pain-related fear avoidance behavior. And of course, it's logical, the more severe the carpal tunnel syndrome, the more limitation you're going to have of cervical side flexion away from the affected side. This is completely logical. But if you ask me, is it necessary to mobilize cervical segments in the treatment concept of a carpal tunnel syndrome, then to be honest, I have serious question marks about that. This is super important. Okay, what's the difference in the history between a carpal tunnel syndrome, a cervical disc protrusion, and a thoracic outlet? So the carpal tunnel syndrome, he has pins and needles while moving the hand. There is a link with wrist movements. There are no pins and needles above the wrist, and as I mentioned before, there is a real clear aspect. He can say, okay, this part of the finger yes, this part of the finger no. If there is a cervical disc protrusion with pressure against the nerve root, then the pins and needles are going to be very irregular, day and night, and mostly not longer than 1 hour at a time, and there is certainly no clear aspect. And if there is a thoracic outlet syndrome, more specifically compression on the lower parts of the brachial plexus, then this is also a nice example of a release phenomenon. Those patients have pins and needles at night. They wake up every night at the same hour because of paresthesia. In the morning they still have some numbness, but every night the same. If they go to sleep at 11 o'clock, well, around 2-3 o'clock they wake up because of paresthesia. So this is very helpful in making a differential diagnosis. And of course, the functional examination in each of one of those cases, is also different. When I come back to the release phenomenon, for instance, you can ask the patient that he sits at home and while sitting, he puts some cushions under the elbow, both sides, so he's actually releasing the pressure on the brachial plexus or on parts of the plexus, and then the patient can wait until the paresthesia are coming. So then in this way you also have a link. Pressure on the radial nerve could be related with a subluxation of the scaphoid bone, could be related with an osteoma or friction against the lower border of the radius. So if there is a structural problem, of course, something needs to be done. If we are lucky, nervous mobilization techniques could be helpful. Pressure on the ulnar nerve could be related to a ganglion. If there is pressure on the ulnar nerves, mostly it's on location 1 and 2. Perhaps if necessary, an infiltration can also be given there. If wrist extension is weak, it could be bilateral, could be unilateral, but if it is unilateral weakness, then there might be several reasons. Radial nerve problem, C6 root compression, C7, C8, and then in combination with other functional tests, as you can see. But perhaps that's a little bit difficult to memorize. Wrist flexion could be C7, could be C8, together with elbow extension and with other tests. How can we make that a little bit easier? Well, on this scheme, you see the extension side, the flexion side, the radial side, the ulnar side. So above, you have from left to right, you have extensor carpi radialis longus and brevis, extensor digitorum, extensor carpi ulnaris. Below, from left to right, you have flexor carpi radialis, flexor digitorum, flexor carpi ulnaris. Okay, everything which is above this line has C6 origin. Everything which is below this line has a C7 origin. And everything which is under to this line has a C8 origin. So, for instance, the extensor carpi ulnaris has C6 components and has C8 components. So that's perhaps a little trick that might be helpful when you are confronted with weakness on certain resisted tests and you have to look for specific nervous structures.